Hey folks, we're back. I'm your host, BKP. We are at Circuit World in Blue Ridge. Good to be home. Good to be here with Dr. William Whaley and Dr. Raymond Tidman. Let me say this. I don't get a chance very often to, I don't know who the other guy was last week. I forget his name. But I don't get a chance very often to watch the program, you know. And I have to tell you, I really enjoyed it last week.
I like to session last week.
Well, no, I like to say, and Rick does a great job, and I like to say that I want to make sure that we're bringing good information. I know we do, but I wanted to see the other side. You know, what are the viewers getting? And I just want to tell you how much I enjoyed last week's segment, being on the other side, watching it on TV.
You could wake up late, get a cup of coffee, sit up in the bed. You didn't have to be up at 4:30 in the morning watching CNN and communist news.
You are 100% right.
Yeah, right. And you came back 14 pounds heavier. I can tell that from sitting here.
All right. So wait a minute. I'm going to tell a story. You ready? No. You said it. You said. So I spent some time with my mom, right?
Yeah.
So my mom likes to, talk about my diet.
No kidding.
But guess who? Hey, so I get up, I do a show one morning, I come in, and there's biscuits, gravy, and bacon.
So, Mom, you're helping me here.
And I said,
Thanks, Mom.
You know what she said? I said, Mom, she said, you only get that once a month. So there you go.
All right, okay. Well, it's not the tie today, it's the jacket.
You made reference that on.
Okay, it's the jacket. It's the jacket.
Yes, I love that jacket.
Okay,
when you bring that jacket, I love that jacket.
3,000 of our troops have been moved to Eastern Europe.
Mm-hmm. Poland, correct?
Okay, 1,000 to Romania. No,
right.
they're going to Poland, and they're moving some from Germany to Romania. But the point I wanted to make was, the Biden administration made a statement that they're probably going to be used to process Americans fleeing the Ukraine. Those are 20,000 something Americans there that have to cross the border and get out.
The Poland border, yes.
Yeah. But I noticed that 2,000 of them were the 101st Airborne Division, and 1,000 of them were striker force.
Oh, wow.
Now, these guys are trained to jump out of airplanes with knives in their mouth, and I think they got a whole bunch of clerks and stuff probably at, Fort Benning they could send if they want somebody to process passports. So I don't believe that we're going to we're not going to move anybody into the Ukraine. We're not going to fight with anybody. But we didn't send a bunch of clerks over there. That's all I wanted to say.
We didn't send the processing team.
We did not.
We sent the team that could jump from the plane.
We did. And
Okay.
the striker force is the ones with the fast vehicles on the ground. And you sent 1,000
Right.
of them, and you sent 2,000 airborne rangers.
No, they got like 30,000 people that work at the NIH and CDC. They could send some of them over there.
They could.
Processing, yes. And they could set up different lines, and they could
Put 'em to work.
they could test them as they come across the
Like
border.
at the airport, the long Z lines like
I'm
that.
sorry. We probably need to get away from this.
Okay, here's what we're talking about today. Both of these questions that we've got, I'm going to do my tie if you don't mind here, so I can talk. Both of the questions today have to do with what in cancer we call survivorship.
Okay.
You treat a patient, you've got a long-term human being, and you've got things that happen. Now, one of these patients we already talked about a month or two ago, and then it's good to come back to see what the concerns of this patient are. And the other one is what is it? It's 8 years out from a real advanced cancer, and it's got to do with how follow-up works and what you do. So let's talk about the first one, because we talked about this a few weeks ago, and we had some anatomy lessons. My brother's a long-term survivor of testicular cancer, had lymph nodes removed from his abdomen, was treated with chemotherapy, and has not recurred in 30 years. 20 years ago, his testosterone is low, and he's been on the testosterone without problems for 20 years and has to donate blood 3 or 4 times a year. He's an athlete and had a clot in his subclavian vein under an old broken collarbone. You remember it? We talked about that about 2-3 months ago. You discussed his case at that time. Now, you remember at that time we said that he needs to get off the testosterone because he had polycythemia, needs to get anticoagulated, and he had a big old swollen arm, big old neck. He could die from that, mediastinal. So He then, so this is what he did. I've been interested to know what he did besides take anticoagulants. He went and got angioplasty. So that means he had to go to Emory or St. Joe's or somewhere, and then they did a vein angioplasty. His arm remained swollen and his chest veins remain abnormal. So that tells you that the circulation is better but not perfect. You may recall he had an elevated PSA. I remember that. It was 15, now it's 12. He has a normal urologist prostate exam. So now he's gone to the urologist, had a digital rectal, maybe he had an ultrasound, I don't know. He has not had biopsies, and he remains on anticoagulants. Now, what do you think's got him bothered? Remember now he was an athlete taking testosterone. What do you think's got him bothered?
He wants to get back to it.
He wants to return to weightlifting.
Mm-hmm. So I'm trying to get back to calculate his age. If he had testicular cancer,
he's 64.
Okay, I was going to say he's early 60s.
His age was in the question last time.
Okay.
He's 64. So he's one of the guys we see at the health club.
Yeah.
Who is a working out guy, and the thing always remember is he was taking testosterone because of testicular failure. He was not an abuser of testosterone.
Right.
So in the health club, you've got the guys that are abusing testosterone, taking it out, monitoring, getting it off the internet.
Yeah.
And we're not trying to support that.
Right.
We're trying to support testosterone replacement therapy for the elderly or the people who've had radiation or treatment that have taken away their testosterone. So we agree this guy could get testosterone, and once we got it where it's not going to do him any harm. So he wants to return to weightlifting and using testosterone. He is very anxious about not getting his prostate biopsy. What do you recommend he do now? Well, I'm going to go back to that weightlifting thing. Because we talked that day, I had called, remember, the National Football League head doctor about what do you see as long-term complications. Mine looks just like his. How often do you see a venous obstruction? He says, well, it's not unheard of. He says, but probably only occurs less than 1/2% of a badly deformed thing. So why did he clot? Maybe he used a half of the 1%. So I would say, don't let him go back to weightlifting until the vascular surgeon says that he's not worried about the obstruction. I think that's not our question to answer. He's anticoagulated. I think that's still the vascular surgeon's business, and it makes good sense. Second, we want to keep his hematocrit down below 47, probably not gone back up because he's off testosterone. Now, he wants to go back to testosterone. I'm happy for him to go back once that we know for sure that he's got the angioplasty, he's on the anticoagulants. But now what he's anxious about is not getting his prostate biopsied. So what this really comes down to is a very healthy athlete who wants to go back to being a healthy athlete, and he's got this mental issue. I guess it's a self-image issue, if you get it, that he's not out there lifting weights, that his testosterone level's low, his energy level's probably gone down, and the only complication that he's got that's really got any, he's got cancer of the prostate, I guess he's worried about. His PSA was 15 and now it's 12. Okay, put up that first one there, because we got to go through the survivorship part. We did not do this before. What'd you say?
Testicular cancer treatment and survivor.
All right, you like
survival.
Survival. All right, we got a survival for you, right? Mm-hmm. Okay, pull that down. You remember, put the next one up because this will be up for just a minute. Lance Armstrong had testicular cancer in his brain, lung, and his liver, and he was dying in Texas, remember? And then they sent him to Indiana, and Larry Einhorn treated him with the Einhorn regimen. And now when you look at the 5-year survival of stage 4 cancer of the prostate that's in your brain and your liver, it's up next to 100%. But you got that up there? So it's as good as early stage prostate cancer because of the magic of the chemotherapy, which really works. So you can pull that down. So this guy right here, this would be just about the same time that Lance Armstrong got treated, if you stop to think about it. I'm sure he got exactly the same treatment because they had to go in and take lymph nodes out of his abdomen, which then would have meant that he had cancer that was advanced.
But Bill, wouldn't you not say as an oncologist that testicular cancer is no longer on the table for this man? I mean,
Oh, yeah, it's over with.
He's
Gone.
30 years out. He's not, okay.
No, what you're following now is the survivorship.
Okay.
The long-term complication of retroperitoneal lymph node dissection, that's circulatory. The low testosterone, that was related to the treatment. This vein in this clavicle got nothing to do with it. That's got to do with him being an athlete.
Right.
But the treatment of the low testosterone, he had a hematocrit in the high 50s, probably wasn't giving his blood as often as he should, and then this, with this little kink up here, he got clotted, and that could have killed him, because it went up his neck, his arms swelled, his neck got big, and if it went much further, it'd shut off his veins.
You're about to get to the prostate PSA question.
Well, I'm going to stick with it. Okay, go ahead.
But my question right now is, what was the amount of testosterone that he was taking?
I don't know the answer. We don't know the answer.
We don't know that, and we don't know what his serum levels were. I mean, he may have been abusing it.
Well, we do know. We do know. I think from the first question that he was being treated for it by prescription.
Okay, so
we would assume that the guy that was doing it was measuring
doing it right. Yeah.
So I'll just tell you quickly. I'll tell you how we do this. Most insurance companies won't pay for the cream. If they pay for the cream, then after the guy's been on it a month or two, we have him come into the office in the morning early, say 7:30, 8 o'clock, get his blood drawn before he would apply the cream to see what the low level is. The next time that he comes in the office, so if that's appropriate, then the next time he comes in the office, which would be 12 weeks later, usually going to measure it about every 3 months, we'd have him come in. If he puts it on at 7 in the morning, we'd have him come in about 1 or 2 o'clock in the afternoon so we can see what it's like at his peak.
Yeah.
So now you've got the range, the guy feels good, and it's quite likely his hematocrit is going to rise. So what we tell him to do is go to the Red Cross, donate blood, or go to whatever, and then we just see how many times a year he's got to donate blood to keep his hematocrit 45, 46.
Yeah.
And that's easy. And PCPs can do it. So that's how he should. So put the next one up there. So this is what he had: secondary polycythemia, and we've gone through that. Once your hematocrit or a percentage of red cells goes above 47%, what analogy do I use? Molasses in January, 30 weight oil in January. It's thick. So you got to keep it below that. You can pull that down. You got to keep it below that. And the only way to keep it below that, if it's secondary and not the bone marrow disorder, is draw it off. Well, if you come to my office and I draw it off, they're going to charge you $1,000 or $400 or something. If you go to the Red Cross and donate it, and I noticed that the blood assurance truck is right out here parked at the Ingalls last night, so it's somewhere in this neighborhood. When you go donate in that blood assurance truck today, it's going to be somewhere. 3 people benefit from the blood. One gets the red cells, one gets the plasma, and one gets the platelets, and you get a cup of orange juice and 3 cookies, and it doesn't cost you $1,000. So most patients want to donate blood in the volunteer blood system so that the world is benefited by it, and they don't have to pay a copay on a $1,000 charge. Right, Ray?
Right.
Okay. So put up that next one. So here we get to the idea of testosterone. So this is the guy at the health club. See all his muscles now. Pull that down. I think we talked about this last time, and Ray was talking about how his nurse practitioner or something made a diagnosis when a patient came in with complaining of a rash and walked over to Ray and says, well, how long's he been using testosterone? I mean, you can see physical findings if a guy's got his shirt off of testosterone in an abusive fashion. Stria, or jaw gets like this, or these brow gets like that, or the face gets florid. So when you're treating a guy with therapeutic doses of testosterone, you don't get any of those. If he's buying it off the internet, then you see it frequently at the health club. So that's the story. Okay. Now, what are the contraindications? Ray commented about this. You don't give this to anybody who's ever had a history of prostate cancer. They've had prostate cancer or male breast cancer. You can pull that thing down now. But when you give testosterone, The urologists are of the opinion that the administration of testosterone does not have a statistical relationship to the development of prostate cancer. And most urological literature would support that. And most urological literature would support the fact that your PSA elevation taking testosterone will occur, but it'll be slow, and it won't go to 50. So you can pull that next one down, and you don't give it to people with heart failure. So and you don't give it to people who have such a big prostate that they're waking up at night to urinate 3 or 4 times a night, right? You don't want to make the prostate any bigger. So there's some, you got to think about who you're going to give it to and who you're not going to give it to. So your idea in this guy is he has a PSA that's elevated. We know that he's been a weightlifter, and we know that he's been on testosterone. Now, we don't know if he's had chronic prostatitis, and we don't know a whole lot about his sexual function. Put up that next one. Now, this is, I think I told you once before, the highest testosterone I've ever seen, a PSA I've ever seen, which was 20-something thousand, was after a guy had ridden a bicycle on the Bragg race. But if you look at all these different causes of an elevated PSA, first one on the list is ejaculation in the previous 48 hours, meaning the guy had sex. Mm-hmm. You got the bicycle there, see, or riding on a boat, being up here, you can pull that down now. So if it has been at this level for a while, the 12 and the 15, and we really don't know whether that's been that way for a year or two or not. Right. We do know he doesn't have obstructive symptoms. We know he's got a normal prostate by exam. Then I would say that he is safe letting the urologist monitor this PSA. Don't feel like on the internet until you start thinking about biopsies when you get to 4 or 10. But he's got a urologist. They've already told us that. So what do I think he should do? I think, one, he should stick to his urologist and let him decide when the prostate biopsy is done. We don't know if that exam included an ultrasound, but I'm sure it did, probably not an MRI. Second, the lifting of the weights, we got to leave to the vascular surgeon. And the testosterone replacement, I'm happy for it to go back on it now, as long as we know, because he's got the angioplasty, that whoever is doing it is monitoring it appropriately, and that he's donating blood to keep his hematocrit in the 45-6 range instead. Now,
the one thing I would add to that is in what I tell my men that are in the PSA monitoring range is that I really don't care about a number. I want to see the trend. Okay, so I over the years will have an annual PSA, and they could be 12. Okay, and it's been 12, 11, 13, 12. They're okay. Okay, obviously we will have worked them up when they got there.
Yeah, sometime along he's had an ultrasound.
He's had an ultrasound or something.
MRI or something.
We will have worked them up, but the primary care physician will have a trend on where their PSA lives. And I have men who have chronic recurrent prostatitis, and they'll be 6, and then they'll come in with a 12, and we'll recheck it 6 months later, and they're back down to 6.
Yeah.
That 12 does not get them, get us all worked up.
I think the last word that he used here that we need to talk about, and look at it carefully here, BKP, he said he is very, very
twice
anxious. The first time the same brother asked a question, he said that he was anxious. And at that time, we wondered whether or not his anxiety was related to the testosterone, which can make you anxious or hostile, angry, or mean, or something, all that stuff. So now we know that the anxiety is not caused by testosterone.
And we also know, and they can't see this at home, but we also know in that area, whoever wrote the question chooses to capitalize every word, stressing this very boldly.
Right.
That's
important to him.
Very, very anxious.
Yeah, but the things that he highlighted were weightlifting, anxiety. So anyhow, that's the story.
Let's digress on that aspect just for a second. As a young man, this man faced down cancer,
and he lost a testicle
Yeah.
And he had a big operation.
Right.
Right.
So, I mean, so he, he faced his mortality at a young age, and he survived it.
Yeah, is
But
that why he's lifting weights and why he's trying to be
yes,
so fit? Yeah,
but
of course it is.
You see this constantly. You have people who, if they come in and they hear the C word and everything in their life changes, and then they go through treatments and they survive, but that affects your personality and your mentation the rest of your life.
Of course it does.
And so I think that some of that may be going on here. That
Right.
he's like, oh, they're using that C word on me again. So what am I going to do about all this? But I'd be anxious.
But I think a guy who lost his testicle in his 20s,
Yeah.
went through chemotherapy, and that retroperitoneal lymph node dissection is a cut from here to here, clearly would have had an emotional change in his self-image.
Yeah. Yeah.
And the fact that he has been a weightlifter, an athlete, and has requested and taken testosterone tells you that a lot of his activities are to maintain his
physique.
sense of virility and vitality, and to spit in the face of the mortality and
Right.
the debility. So that's where the very, very anxious came from.
Right.
Now this is where support groups are great. This is where counseling is great. So anyway, this is what we call survivorship.
Yeah.
And that's an important question, and I was happy to answer it again.
Folks, we always want to thank Georgia Cancer Specialists affiliated with Northside Hospital Cancer Institute for our segments and giving Dr. Whaley this opportunity to answer these questions. Now, our second question this morning.
All right. Well, this is a great question because this is another survivorship question, and you got to always remember you're treating a human being and not a chart. My grandmother is 82 years old, and in 2013 she had triple positive breast cancer, and in 2019 was last seen by her oncologist. She quit going because of orthopedic issues and transportation problems. So maybe she doesn't have a car, and she doesn't want to ride the subway or something else to get to the doctor. 2 weeks ago, she went to the emergency room and was found to have cancer in her bones and lungs. So she must have gone in there with shortness of breath or a backache or something. Do you think we should go back to the oncologist for evaluation, or should we suggest hospice to her? If you stop right there, this woman doesn't have anything wrong with her except her age.
Right.
And a social aspect that would not provide transportation, and she may have an orthopedic issue that bothers her. Well, I'm 82. I've had 2 hip replacements. My neck hurts every day. So if in essence, that lady not a whole lot different than me. So she was just got off her medicine, and 2.5 or 3 years later, I think her cancers recurred in her bones. She was triple positive. So I don't think you call for morphine and ice cream. I think you treat her. Put up this next one. This is really a good question to go to because this is, again, survivorship. These are the old survival curves, BKP,
Yes.
for people who had positive HER2 new. Now, the estrogen and progesterone receptors, those have always been beneficial, right? You could take hormones. But if you had the HER2 new, you got a bad actor because you had a 50% chance greater it would kill you. And that's this bottom number here. Before, pull that down. What's that say? New treatments. All right. So, got the next one up there? All right, so now we got new treatments. Pull that one down. All right. So now you've got hormone therapies, triple positive. Got the next one up, triple positive. Because this is not a real high number of our breast cancer patients. We had a triple positive question about 6 months ago. Triple positive means the hormones, estrogen and progesterone, were positive, and this bad genetic marker, HER2 new, is positive, and that used to be a death sentence. Pull that down. Now, I don't know how to, very quickly, we saw this a couple of weeks ago. Triple positive is only 10% of breast cancers. That's that one right there. Got that up? Pull it down. Now, here's the story. I wish I'd known. No, excuse me. I don't wish I'd known. If I'd bought stock in it, it'd have gone bad, and it wouldn't have been a good drug because I know nothing about investing. Put that next one up. When Herceptin came out, and that's been a decade or more ago, it totally changed the outlook for people who had that genetic marker and changed it from a death sentence to a benefit. Because a non-toxic antibody that you can give for 2 whole years when the patient doesn't have active disease, instead of chemo, you give a few months to prevent recurrence, it dramatically improved the outlook for patients who had triple positive or HER2 new positive cancer. Okay, pull that one down.
Sorry about
That's
that.
somebody saying the internet went out.
No.
Okay. So pull up the next one. We're gonna let BKP look at the algorithm. Look at the algorithm, BKP. All right. Now, advanced cancer is treated on. Come on. What's that say? I got to put you to work.
Biology of tumor.
Okay. Now I've told you before. Pull that down. Only the things that have been important in the last few years are genetics, drivers, and biology. Not more surgery and not more radiation. Put up that next one. You've seen this cartoon before. This drug Herceptin goes in here and blocks these receptors and allows natural immunity to kill the cancer cell. Pull that one down. All right, BKP. We won't even show that next one. The next one just shows how we've got to this point where you took patients that had that positive antibody and you gave it for 2 whole years, which I'm confident she probably got, and then you kept them on hormones. So when she stopped those hormones, she let their cancer grow back. It took, 2.5 years or something? Yeah, 2.5 years. So yes, she's got advanced triple positive cancer now. She's probably in pain and short of breath. I would immediately get her to the oncologist, because she's got about a 90% chance you can turn that thing around in 6 weeks by treating her. So yes, she looks bad now, but she's my age and she's got the same issues I got, and I'd say quit thinking about hospice and find some transportation for her. That seems to be the issue, how to get her to the doctor. She likes her oncologist, so she didn't quit seeing him because she couldn't pay him or she didn't like him. It was a transportation, you've got family issues, right? You got to get the elder. Maybe she's got cataracts and can't drive anymore. But anyhow, my advice is get her back to the doctor and get her treated. There.
Again, thank you very much. What's the news of the day? I mean, do you have any news of the day? COVID's over with.
Well, man, I sent you a list. Where'd that list go, Ray?
I mean, at least that's what the media wants me to believe, right?
No, the media says it's not over. Not over.
Wait a minute, but there has been some enlightening in several states that.
Oh, yeah. Maybe it's politically not a good thing to be locking people up.
The media doesn't say it's over, but the media has found some other things of importance.
Yes.
Okay.
No, wait a minute now. You've got WHO and CDC and I won't say Fauci, telling you to get boosted, wear your mask. They haven't changed that, right?
No.
Right?
No.
Okay. Now you got Johns Hopkins telling you locking people down hadn't helped a whole lot, and you got the guy from the CDC in Atlanta saying that if you lived in Atlanta, and I'm sure it would have been the case here, and you were on the street and out of your house between December 15th and January the 15th, you probably got the Omicron variant, even if you were not sick, because it was so infectious that if you circulated out there, you probably got it. I know so many people that said, I had a cold, and then my sister, she got tested. She was positive, but I didn't feel bad. I didn't get tested. Well, I think those people all had it. So you've got a whole much more people that have gotten the disease in the last 12 weeks, I think.
Are you going to use the word herd?
No, I'm not. You can
You're not allowed to say that anymore.
You could. No, I'm not going to say that because Fauci will come out and kill me. But
herd.
Herd.
We'll study on that later.
Okay.
The word of the day.
All right.
Herd. Sorry.
All right. Well, you asked the question here, and I think it's on this one. Here you go. The last thing in the news says what?
Prior infection offers less protection against Omicron, studies say.
Okay, so if you believe that, I got some swampland in Arizona to sell you, or a bridge in Brooklyn to sell you. I believe that the natural history of this disorder, because we know that the shots didn't help you.
No.
Now, they kept you out of the hospital if you were fine china, and they kept you from going on the ventilator if you were fine china. But if you were ready to die, we both think you probably had it. Jane probably, my wife probably had it. I had 2 chemo nurses out last week with it at the same time. That's out of a group of 6 people in that room. So it's still going on. And when you say that the media is saying it's over, I don't. Everybody that talks to the media says it isn't over and go get shot. And I think you have some people, and I'd use Johns Hopkins as the best. People were quoting Johns Hopkins the second week of the epidemic because they were the first ones to have that worldwide map. So they have got some gravitas to what they say. And what did they say, Ray?
Well, thanks for pitching me that one. Well, first of all, let's make a big point here. Johns Hopkins is the largest, most pristine medical center to come out with such data as this, because it's contrary to the song that we've heard for 2 years. 2 major studies. Let's talk about the Omicron prior infection, natural immunity. That study showed that natural immunity is superior to the vaccine and long-lasting. Okay, so if you've had Omicron, if you had any prior infection, you have long-lasting immunity. Number 2, that long-lasting immunity doesn't require a blood test because we don't know what those levels mean. But if you've had a positive PCR test anywhere in the past, that will say that you are a survivor of this virus.
Omicron. You're going to get it.
You may get it, but you're a survivor and it's not going to bother you. That's great news.
Let me stop you right there.
Yeah.
Okay, here are the Fannin County numbers. We've had 4,074 cases, and our weekly case rate is 11 cases per week. Mm-hmm. We've had 130 deaths. We had that how many weeks ago? Was it 130? 3 weeks ago. We're having 0 deaths per week. So what Ray just said, you're getting the disease, you get a test, you go on the test, you go on the case list, but you don't go on the dead list.
Right. Okay, so people need to be really reassured that our bodies are very good at its immune system, and they're superior to the vaccine. Here's the other thing that's just the politicians ought to be falling over and apologizing. Okay, if you tell people that they can't have their job because they're not vaccinated, and half of those people are carrying antibodies, you're throwing away half of the people who have superior protection from the virus. That's very stupid. Okay, very stupid. So people who've had a positive PCR, you're safe. Definitely, as Bill and I have been saying forever, go about your business. Okay, the second study is even more important. The second study was a compilation by more the economist folks, the public health folks. And they took 24 studies that had looked at different aspects of shutting down, of locking down. Okay? And they compiled all of that data, and they answered 2 questions. The question number 1 is, did it stop? Did all of those maneuvers stop the spread of COVID? The answer was no. It was like 0.2% benefit. So all of the mitigation problems, all the stuff that they quote did, the grandiose statement by Dr. F, where he said these mitigation things will stop hundreds of millions of infections and save millions of lives. Now that's Mr. Science who said that. Was flat out wrong, completely wrong. This study shows not true. Okay. More importantly, from those efforts, we've talked about this for 2 years, stopping cancer screening, stopping heart attack treatment, stopping cholesterol care, shutting down businesses, impoverishing people, stealing,
increasing domestic violence. And a new one I heard today, which I hadn't thought about, was when you made kids go on the internet to do schools, you put internet in their hands when they don't have the emotional ability to handle the internet in general, and it increased the internet abuse of kids.
Thank you.
By about 200%.
Thank you. Exactly.
So you expose the children to you take away their childhood, you take away their learning, you expose them to evil. Anyway, it's a bottom number, a low number is per year 125,000 people dead from those mitigations.
All right,
now we talk. I want you to jump in here. Bill and I talk all the time about risk benefits of a medicine. Okay, every week. Okay, what are you going to benefit from this medicine? What are the side effects? What do we have to watch from the side effects?
Baby aspirin.
We had these arrogant people. I'm hot about this. Come out and say, here's the treatment, and when asked about the side effects, they were saying, well, that's not our problem. Well, then you're not an MD. I'm sorry. Wherever you got your MD was a cookie cutter or back of an envelope thing, because an MD has to look at both sides of a treatment, and they have to tell the patient about it, and the patient has to consent. So those people who came out and said, here's our treatment, we don't care about the side effects, now they are guilty of killing 125,000 people a year. That's 250,000 people, lives who are on their say. And I don't know when they're going to be held accountable, but we must never do this again. We must never do this again.
Go ahead.
Other thing, okay?
Go for it. Go ahead.
There's physicians are incredible people, study all their lives and do incredible things. But there's none of us smart enough to hear about a new disease and a month later come out with a treatment that's going to cure things. None of us, okay? But these folks did. They came out and said, oh, God, here's this thing from China. Here's the answer. Everybody go do this, and we're all fine. Arrogant beyond means. So anyway, your point.
Okay, well, we'll go to the next one. Because physicians are really good at trying to figure out. What's that top headline say?
As CDC holds the line, doctors debate lifting mask mandate.
Okay, so what doctors are doing is trying to weigh the data.
All right, I got the all-star panel over here, but
all right,
no, I got them over here, but this is important. Now, let me take that, not to cut you off. People know that you're my physician, and you have put me on some medication. I'm not violating HIPAA. I can say what I want. But what I'm saying here is, you and I, as patient-doctor relationship, you have never prescribed anything or whatever that you didn't know and want to know in a couple weeks. Okay, how's this making you feel? Yeah. Are you getting acclimated to it? Is it working? Right? I mean, is that
that's
not
what we do?
Right, that's what you do. We didn't do that. We put this list out. So what I'm asking you this morning is, and I'm going to get pushback out there, but are you saying that when we were studying to see, and we had people in grocery stores with rubber gloves, because we were studying to see how long COVID lived on cardboard, plastic, and surfaces.
That was important to do, though.
Well, wait a minute. What I'm getting at is, are you saying that right now where we're at today, if we would have lived our lives and moved on, that this is possibly right where we'd be today?
No, we'd be better off today.
Okay.
We'd be better off because at least we'd have 250,000 people that wouldn't be killed by our treatment.
Well, the other thing is we would have had kids in school for 2 years.
Yeah, we wouldn't have
We would have had a much diminished domestic violence, alcoholism, drug abuse.
Poverty. No, we'd be better off. But there's something in your statement that I want to reflect on. They didn't ask the question, how are you doing?
Right.
Okay.
That's what I'm
They
thinking.
didn't go back to society and say 2 weeks later, are you better? No, they just said, we were kidding about the 2 weeks. We're going to keep going. And we're going to keep going, and we're going to keep going. And now we have
flatten the curve.
Yeah. Now we have data from a prestigious medical center saying you're killing people, they're still going.
Say Johns Hopkins a few more times.
Johns Hopkins is a great school.
Because people have believed in Johns Hopkins since day one, and they've been skeptical of WHO and CDC since day one, And Johns Hopkins presented data repeatedly telling the case rates are high, the case rates are high. And when Johns Hopkins turns around and gives you this information, you got to say, that's something.
Right. So let's close with this.
Donate blood.
I did not, no. I did not get, I got to say, I did not get to read the entire article. I got the headline, I got started in it, and got sidetracked. But I read something that said that the vaccine, they were looking at changing the space of time between the first shot and the second shot because of some studies on the heart.
Well, not in this article. That's not in this article.
Forget about it, because we've known a long time that myocardiopathy, myocarditis, and pericarditis are increased in people who've had the shot. But with 6.5 billion shots given, or 2.5 billion, it's still a low number. And I've got a patient, I've got an employee that has it. So,
I just heard that they're thinking about changing the space of time between the two shots.
That's a study that's going on. We don't know the answer. As Ray says, we don't know the answer. Yeah. So let's assume, for the sake of argument, that you're still talking about fine China. I want fine China to have the shot. Period. Okay?
Okay.
I'm not going to ever go back off of the fact that if you're elderly, overweight, diabetic, you got fine China. I don't want my grandkids and their friends and the ones that go in school with them to have to take the daggum shot. Period.
No. You got a closer?
I'm good.
Donate blood.
You good? Donate blood.
Donate blood.
You have to.
The thing's out there somewhere today.
Yeah, you have to get to work.
I do.
And you probably have a patient up there. We got to get you out of here. Thank you very much.
I've got a nurse up there. She's going to want to know where I am.
Thank you very much, folks. Thank you, Georgia Cancer Specialist, affiliated with Northside Hospital Cancer Center. We'll be right back with the All-Star Political Panel. Thank you, Raymond Tidman and Dr. William Whaley. I appreciate you guys. Take a break.